So another part, and thank you very much for inviting me again. Even if the weather is not so good, I was expecting sun, but perhaps. Anyway, I will completely change the subject and we'll speak about optic neuropathies and the clues and the tricks about this very interesting subject. And as you know, optic neuropathy, as a clinical definition, it is a reduction in the visual acuity and often color vision, with a vision which is less bright than usual, and there is an impairment of the visual field. And if it is unilateral or asymmetric, there is abnormal pupillary response, which is called Marcus Gunn sign. And sometimes, but not often, there is modification in the optic disc, which can be edematous or atrophic. And imaging gives to the clinician the element of proof needed to treat the patient and to know the etiology. And this imaging could be the CT scan, but not in fact, because the analysis of this optic nerve is very poor, and we have very poor information about brain lesion, especially about white matter. So we use MRI. And if you have a patient that comes with impaired vision and the clinician says, oh, please, a CT scan just to eliminate something, you say, no, I prefer wait for 1 or 2 days, but I want to perform an MRI to be sure that there is nothing wrong about the optic nerve. Because this MRI will give an excellent analysis of the optic nerve, but also of the brain surrounding, and especially white matter and meninges. And how do you do this examination? You have to have a look at the complete optic pathway, anterior-optic pathway, from the posterior aspect of the optic bulb until behind the optic chiasm to the optic radiation. And the best way to do this is to perform thin slices, 2 or 3 millimeters, at best in the coronal plane, because you avoid missing lesions, and it has to be perpendicular to the optic nerve axis, and it's that way. You perform a sagittal T1 or the sagittal scout view, and you take the optic nerve, and the first slice must be just positioned at the posterior aspect of the optic bulb, and you go to the sagittal plane to be sure that you examine the complete chiasm, optic chiasm, and a little bit of the optic radiation, and you can't miss the lesion. And of course, it has to be of good quality. Donc, if the images are blurred because of patient's movement, you have to redo the sequence. You must be sure that you have a good quality image, and you avoid eye movements. If there is a lot of makeup, please you ask the patient to remove the makeup because the examination. And of course, you have this basic protocol is based on T2 and T1. The T2 is very important because you are going to depict hypersignal, and you are going to see the side of the optic nerve that can be enlarged, atrophic, or normal. And the T1 with injection will give you information about blood barrier rupture, inflammation, and of course, as the optic nerve is in the fat, you have to use fat suppression to see this contrast enhancement, either the usual fat suppression or the Dixon sequences. And of course, as the optic nerve is part of the brain, you have to make an examination also of the complete brain to disclose the etiology of the optic neuropathy, and we'll see that a lot of neuropathy are due to MS. To depict other identical lesions that give clues to the diagnosis, such as other meningioma, for example, other lesions that make you think that there is metastasis. You have to explore the entire on flare and T1 after injection, and the best way to make a complete examination is to use 3D sequences, and of course it's not available on all the machine, but if you have the possibility to perform 3D sequences, it is the best way to see if there is any lesion. Of course, you add, depending on the clinical onset, other sequences such as diffusion, such as, MRA. It depends on the clinical onset. For example, this is a sudden double bilateral acute visual loss, and in fact it's due to infarct in both cortical areas. And when you inject the patient, think of using the contrast media. If you have a suspicion of something arterial, use the contrast injection to study the branches of the aortic arch. If you have something that may be a thrombosis, use it as the venous examination. If you have a tumor, use it during perfusion, or either T1 or T2. Use the contrast media because it can be dangerous, and you must not take, okay, I injected, and another MRI with another injection has to be perfect. Try to do it at first time. And of course, the protocols will be selected depending on the clinical presentation. We have other sequences. We don't use them in our routine practice. It is still a research field, and I think that in a few years it will be used perhaps in every protocol. But for the moment, for example, I show you fiber tracking. It's not useful at this moment. So I will give you some clues according to clinical presentation, which is the most important thing you have to know, because depending on the clinical presentation, you will organize your protocol. The first clinical presentation is a patient that is coming because there is a rapid visual loss, more or less painful. And the question is it or not an optic neuritis? The neuritis is often revealing a multiple sclerosis, and as you probably know, 70% of all optic neuritis are due to multiple sclerosis, known or unknown, and unknown often because more than half of the cases it reveals the disease. There is a big study in US that lasted for years, and that shown that optic neuritis of the multiple sclerosis is more woman fact, and it is shown in young people, and the specific characteristics is that the optic nerve is inflammatory. It is not specific of MS, but it's specific of inflammation, and as in everywhere else in the body, the optic nerve is enlarged. It is an eye signal on T2 image, and there is a contrast uptake after injection. The location of the lesion can be inside the orbit or can be in the optic nerve in the intracranial area, and this is an example of two different types of optic neuritis. On the right side, it is an acute optic neuritis with a bright signal on T2 images of the optic nerve and a big contrast enhancement. And on the other side, there was a former optic neuritis which lasted for 3 weeks. And you see the signal of the optic nerve is low, and the signal of the optic nerve also on T2 is lower than on the other side. And of course, there is another lesion that shows that it's probably optic neuritis. 3D flares have a lot of advantage on the 2D because it shows the complete brain. It allows to see the specific lesions around the corpus callosum, for example, or subcortical. It shows the lesion in the spinal cord because often your 3D is large. And it shows this sign, which is very interesting because it is targeting your attention to the optic nerve. As there is an inflammation, the CSF around the optic nerve is modified. There is an eye signal of the CSF, and it shows you that there is something wrong on the left side, and you focus your attention on this side. And of course, 3D T1 after injection gives you the notion of activity or not activity, which orientates the treatment. But of course, an optic neuritis is not always multiple sclerosis. It can be, for example, DEVIC disease or Myelitis Optica, which touches also women, rather young women. And this is a case of this disease. It's 3 years ago. This young one complains of left visual loss, and she has a long lesion which is seen in the intracranial part of the left optic nerve. There is nothing on the brain, and there is just this optic nerve that is enhancing. 2 months later, she complains from left arm paresthesia, and so we perform a spinal cord examination, which shows a very large lesion, very inflammatory, very bright signal on T2 images with contrast enhancement, and those two features are very evocative of a neuromyelitis optica. And a few years later, there is more lesions on the brain. There is a relapse on the right side with a long lesion which is in the orbit at this time, and there is a specific lesion on the brain which is around the aqueduct, the cerebral aqueduct, and this is the area postrema, which is rather specific of this disease. And on the T2 images, you see the small left optic nerve, which is atrophic and a little in hypersignal, and the right optic nerve, which is inflammatory and big. So this is a white or idiopathic demyelinating disease of the central nervous system, which touches more women than men. And in 2005, the discovery of aquaporin 4 antibodies helped identify this disease, and it is an arthropathy. And it is a very inflammatory arthropathy. And in biology, these NMO antibodies qualify the disease. And it is when you have something that could be a DEVIC disease, when the dosage is positive, it is a strong argument for this disease, and this is very important because the treatment is very specific. And on MRI, we used to know that there was an optic nerve inflammation and spinal cord inflammation, and we know now that there are a lot of brain lesions also. When I began to hear from this disease, it was supposed that the brain was normal. In fact, now we know that there are specific lesions in the area postrema around the ventricles, and even on the white matter, on the hemispheric white matter, with large lesions that can enhance and that sign the diagnosis. If you have some doubt about different diseases, you can use susceptibility weighted images, and on MS, it is told that in the middle of the lesions, it is supposed that MS lesions are around the veins. You can see very well the veins. And when you have a white matter hotspot with a vein inside the lesion, it is an argument to say that it's probably MS. This ADEM, or acute demyelination encephalomyelitis, mainly affects children. So it's rare in adults, and it is generally induced by either infection or vaccination, and it is a general disease. There is fever, there are neurological signs, and it touches white matter, but also gray matter, and also cranial nerves. So you can easily make the difference between MS and ADEM, and this is an example in a child of 14-year-old with little lesions here, which all enhance because normally it evolves in one shot, and both optic nerves that are enlarged and are enhanced after injection. Sarcoidosis also is a frequent lesion that gives optic nerve alteration. Knowing that it is an inflammatory general disease, that often there is optic nerve alteration and also other inflammatory lesions, such as a lacrimal gland lesion, as I show you here, the lacrimal gland. It can touch the optic chiasm, and it can touch the meninges. It is very often bilateral, and if the corticosteroids are not strong enough, it can be relapsing. And this is another case. I showed you images from women, and now I show you a young man that had a rapidly unilateral painless optic nerve impairment with optic disc hyperemia, which is rather seldom, a margin blurring, and peripapillary telangiectasis. And if you look at this MRI, the optic nerve on the right side is normal. On the left side, there is a little, perhaps a little hyperintensity on the optic nerve, but the optic chiasm is strange because there is a bright signal of the middle central of the optic chiasm, and it is followed by a hypersignal on T2 of the optic radiations. After injection, there is a small enhancement. And on flare sequence, you can see again the inflammation of the left optic radiation. This is an image we are not used to see. We see much this disease at this stage later on, when the person, the patient, is sometimes blind, because this is a disease that can lead to blindness, and when the optic nerves are very small. This is a Leber disease. And when you have a young man that shows something that could be optic neuritis, but there is no pain, and the optic chiasm is specifically modified, you must think of Leber disease. It is often guys, of course, and it is a mitochondrial DNA mutation that affect the optic nerve. These images are not well known, but you have to think of this once you meet the case. When it is brutal, it's very easy. It's either trauma, either something like stroke or hemorrhage. In the trauma, one examination, CT scan. Why? Because it shows very well the fracture that will affect the optic nerve, and this is an example of the optic canal fracture with some bony fragment within the nerve. But sometimes the visual loss is complete, it's just after the trauma, and the CT scan is normal. So perhaps it's interesting to perform MRI, and sometime on MRI you'll see this very specific image, which is a fracture of the optic nerve. This fracture is always seen around the apex of the orbit. It is well seen on proton density images, also on T2, and if you see the patient like 15 days after the trauma, you'll see a slight enhancement because it is a scar. It is very important. Why? Because when you have, it's young people, when you are young people that has a trauma and there is a visual loss, you must tell the parents or the guy, it's over, or oh, you have chance to perhaps it will be better. When you have this image, it's over. The eye is lost. And so you have to organize things knowing that this person will have just one eye for the rest of his life or her life. It is very important to say the things, and that's all. And don't try to, it's difficult with one eye. Okay. When it is a stroke, sometimes you can see the stroke on the optic nerve. You can see anterior optic nerve ischemia. It's a spot, bright spot on diffusion with a low ADC. And it is very specific because it's sudden, and on the visual field you have a loss of either superior or inferior visual field. And sometimes, as it is a stroke, there is an edema and the fundus. More seldom is the posterior ischemic stroke, which is seen on the optic nerve. It is like in the brain, and there is an hypersignal on diffusion, and the ADC is very low. It's rare. It's very rare. When it's transient, when the visual loss happens, and after 1 hour it disappears and it goes again, you have absolutely to see if there is something wrong about the carotid artery, because you have to eliminate, to rule out a stenosis, or to make the diagnosis of stenosis, which can need a treatment in emergency. And so the best way to see this stenosis, I think, is CT scan with contrast enhancement. It is better than ultrasound because ultrasound can't see the complete carotid artery. And it is better than MRI because on MRI, as you know, you can't exactly grade the stenosis. And when the visual loss is progressive, there are many causes. Sometimes the patient describes the vision loss progressively. Sometimes it's just discovered because he goes to change his glasses, and the optician says, but you lost your vision in one eye. And the main problem is the compression. Why? Because we can hope that if we remove the compression, we can improve the vision. And the main enemy, the first enemy of the optic nerve is the meningioma. And to see if there is a meningioma or not, you have to use T1 with gadolinium and facet. And on the first course, we saw a very nice example of small meningioma that was in the apex of the orbit and was mimicking optic neuritis. And the meningioma, I showed you a big one, but they can be bigger, they can be smaller. Just modify the optic nerve. On this case, you can see very well the optic nerve. This one is just thinned by the lesion. And the meningioma, of course, can grow around the optic nerve, because around the optic nerve there is meningeal layers, and it can be within the orbit. And when there is a meningioma within the orbit, the optic nerve is lost. Not now, but in the future. But until the vision is completely lost, we do nothing. The only thing you have to do is to check the orbital apex, because the main problem of this meningioma will be that it will grow backwards, and it will grow in the meningeal layers, and the risk is to go on the other side and compress the other optic nerve. And so the only thing you have to do is T1, facet, gadolinium, and the axial plane to see what's happening on the apex. And when you have this is another example, and sometimes it's very difficult at first sight to see if there is a meningioma or if it is something inflammatory of optic neuritis. Of course, in this case, you can see a little the optic nerve here and here, but there is a clue. For a long time, we perform CT scan because we know that there are calcification on the meningioma, and if on the CT scan, as in this example, there is a calcification, probably it's a meningioma. But we now have a new sequence. This, again, susceptibility weighted images, and in this case, you can see very well that this calcification is really very well seen on this susceptibility weighted image. So when you have a lesion of the optic nerve and you wonder if it's a meningioma or not, just add this sequence on the image, and sometimes, even if you see it's not a very nice image, sometimes you'll see the calcification, not always, but it will show you that it is a meningioma, and the treatment and the way you are going to follow the patients is completely different than the way you follow an optic neuritis. Just a few words about the glioma, which are really devoted to children. It's rare in adults, and it's often plastic astrocytoma. So, like in this case, you have often a cystic component and something that enhances, but it's like all the astrocytoma, you have all kind of lesion. And in the infiltration, just a few words about the leukemia. All the blood disease can infiltrate cerebral structures and infiltrate the cranial layers and infiltrate the optic nerve. And it is a young patient that had a leukemia and a visual loss on the left side was progressive. And when we performed the MRI, there was an enlarged optic nerve, not very bright on T2 image, and enhancing moderately. And on the flare sequence, again, this target sign, there is something wrong on the left side with something that is very bright. Something is wrong here. But we had diffusion. And on diffusion, you can see very well that as this leukemia is made of very small cells and no interstitial liquid in between the cells, there is a restriction of the diffusion and hypersignal on the B1000 and ADC, which is low. And it gives clue to the diagnosis. It could be also a lymphoma. And a few words about normal pressure glaucoma, because it is very old-fashioned, and a lot of people, a lot of ophthalmologists now send people and say, do you know if this patient who present a visual loss progressive has or not a glaucoma? And so how can I say, because a glaucoma is eye disease. In fact, glaucoma is a vascular disease, and more we know that glaucoma is due to a process that touches first optic chiasm and then optic nerve, and you can have glaucoma without high pressure in the optic bulb. And so when the pressure is normal, ophthalmologists just miss the diagnosis, and we are here to help them. Often the optic nerves are normal in the orbit, or can show this little cyst just behind the papilla, which is a very good sign of normal pressure glaucoma. And the patient have a small optic chiasm. A small optic chiasm is very well seen on the sagittal plane. It is very thin. Remember, the optic chiasm normally it has like a diablo shape, and it is very thin, and sometimes it's so thin you can hardly see it, and it is very specific of normal pressure glaucoma. So when you have a patient that is old, I mean more than 80. No, I'm older I am. The age is to the 100 years and more, but after 50, 60, and there is a vision loss, and there is no clue in the ophthalmologic examination, look at the optic chiasm. If the optic chiasm is thin, it is a glaucoma. For toxic metabolic, think of irradiation. Irradiation can impair the optic nerve and optic chiasm less and less, because now that they are very organized, and the location of the irradiation tries to avoid optic pathway. But sometimes you'll see complication of this treatment, and as this is a vasculite, you have enhancement that is long-lasting, and hypersignal on T2 image. The main problem is that when you have a patient that has been irradiated and there is something wrong in the irradiation field, is it a relapse or is it a toxicity of the radiation? And this is an example, my mistake. I thought it was a complication of radiotherapy because the patient went very well. He had been irradiated for a pineal tumor, and there was this little hypersignal on T2 image and a contrast enhancement of the optic nerve. And I said, okay, it's optic neuropathy, it's normal. But 1 year after, it was not optic radiation neuropathy. It was a relapse of the lesion. So be very careful and try to avoid missing 1 year. When you have a doubt, just tell, we are going to perform MRI 1 month after, and to be sure that you don't miss the relapse of the lesion. And at the end, when there is a papilledema, it is very frequent. The clinician calls you and say, there is that woman and she has a bilateral papilledema. I want to rule out a tumor, a thrombophlebitis. Think of idiopathic intracranial hypertension. And when the brain seems normal, look at those little signs. First, when the brain is normal, when there is no sign of tumor, inject contrast medium and look at the venous system and look for this sign, which is a bilateral stenosis of the lateral sinuses. Look at the CSF and look at the perioptic spaces, and when they are enlarged and seen until the apex of the orbit, when the CSF spaces around the third nerve are enlarged, when the Meckel cavum are enlarged, when there is an arachnoid cell, an intracellular arachnoid cell, it is idiopathic hypertension. And this is very important to make the diagnosis, because if you don't make the diagnosis, the patient, who is often a lady, who gained weight in a short time, at this very moment, you risk this. You risk optic neuropathy with atrophy of the optic nerve, and it is a big cause of blindness. And in US, for example, where there are a lot of obese people, there is really a struggle against this disease, because it can destroy the view, and so when you have a lady, it's often ladies, who is a little too fat and complains of headache, don't forget to study the venous system, and don't forget to perform an T2 images, focus on the optic nerves, because if you you have those signs, it is an idiopathic intracranial hypertension, and there is a specific treatment. And something new, the last slide, after 15 anti-MOG antibodies. There are antibodies that target myelin oligodendrocyte glycoproteins. They were known forever, but they were not specific and not used because they were always positive. Now we have new method of detection, and they are more specific. And now, if they are positive, they rule out NMO, they rule out MS, and they allow us to put a name on all the idiopathic optic neuritis. We didn't know where they came from, and on relapsing optic neuritis, which were complicated because they were optic neuritis that were treated by corticosteroid, and as soon as the corticosteroid were stopped, they were relapsing, they had corticosteroid again, and they were relapsing, etc., and it's complicated. And if we compare this anti-MOG neuritis to NMO, the sex ratio is 1. No more women than male. The optic nerve lesions are often bilateral, and they are anterior with frequently a very important disc swelling, edema. And the visual prognosis is better. So it's important to make the difference. Just a few images with this edema. You see that the vessels are making this shape, meaning that they have to go up the edema. The optic nerves are enhancing. The lesion is anterior, but also on the intracranial nerves. Another example, this target sign of the flare sequence, we know that there is something on the left side. Of course, it is flare with fat suppression. And on this side, it is a 25-year-old woman. There is a possible optic neuritis on the left side. And on the T2 images, perhaps there is something that's really, the signal is the same. We have 2 spots on flare. There is a small edema, and the only sign that is strange that there is an enhancement of the optic nerve. 1 week after, as she's worsening, and the papillary edema is very important, and you can see it very well on the flare image. And look at the flare. The edema is always very well seen on this flare. We perform again the MR, and this time the optic nerve is enlarged. It is high signal. The contrast enhancement is very well seen. And on the Dixon image, and why is it important to use fat suppression on after injection, is because if you don't use fat suppression, it is very difficult to see the enhancement. And when I use fat suppression, I see very well the complete contrast enhancement of the complete nerve, and it is an NMO with an anti-MOG positive. So if you must remember something, there are a lot of causes to optic neuropathy. MRI has to be performed, and don't hesitate to do again the images if they are blurred. With T2, T1 gadolinium fat sat on the coronal planes, the depiction of the lesion is excellent. The specificity not so good, and the help will be given by brain examination and clinical onset. Thank you very much.